there's some very promising work coming again out of Europe, this group that's very enthusiastic about the use of pharmacologic management of hemorrhage. In fact, in some respects, showing more promise than what I just presented you in terms of tranexamic acid. That being said, I think the same cautions apply in this careful balance of hemorrhage and thrombosis. And many of availability in the United States is an issue for many of us for now, but I think I just listened to Frederick Mercier present what his thoughts were on it, very enthusiastic, but again, this is the same group that's very enthusiastic about the use of tranexamic acid, and you can clearly see that I fall into a little bit more of a skeptic camp in terms of the use of that drug.
Okay, question for the panel, the ratios of FFP versus red blood cells, 1:1, 1:2, or what we do at Stanford, 6:4. What is the feeling? What does everyone use?
5:3.
We use 6:4. That's just, it's a little bit controversial. There's different, as you know, there's some evidence supporting one, some the other. I think the point is that once you're into a moderate to severe hemorrhage, obviously none of us are going to do that with just 1-unit transfusion or 2-unit transfusion, but once you get into, especially obstetric hemorrhage, at a minimum you need to be on top of the coagulopathy and anticipate whatever. That's just what our hospital provides. There's 6:4 based on how they read the literature.
Right, I would say it's okay, right? You don't know when you go into the massive transfusion sometimes, but after the first 2 pack cells, you should be thinking 1:1.
Okay. There's a lot of questions about oxytocin, so I'm going to throw into, and by the way, I apologize because there's so many questions, we're not going to get through all of them. First is IV oxytocin versus IM, so sticking it into the uterus, in intramyometrial oxytocin versus intravenous. Any evidence of efficacy, one over the other?
There's no evidence of increased efficacy when it's injected into the uterus that I know of. And it also doesn't make sense to me because it still, other than the little spot where you inject it, it still has to be absorbed and then transported to the rest of the uterus. And in fact, that little spot where you inject it, you're going to cause contraction, thus impeding blood flow and impeding its own absorption. And so it's a fancy way to give it IM, and it's maybe even less effective than just, like if a patient doesn't have an IV for some reason, we sometimes give it IM, of course. But
Certainly less predictable.
yeah. It doesn't make sense to me.
All right, question for routine C-sections are high risk. When do you decide to type and screen, cross-match for patients? Do you routinely cross-match? Do you go it alone and call MTGO negative blood? How do you?
That's a good question. I know on admission everybody gets CBC and type and screen. We have O negative blood on the unit, as well as able to call for the massive transfusion protocol, which is also O negative blood. The head of our blood bank has assured me multiple times when I've asked that it's as safe as cross-matched blood.
In someone who has a negative antibody screen.
Right, yeah.
Similar.
Same.
We type and screen everyone, and as long as the antibody screen is negative, you should be able to get so-called cross-match blood. I mean, most blood banks don't really cross-match anymore. If the antibody screen is negative, they give you blood off the shelf. If the antibody screen is positive for some reason, obviously that's another story. But as long as the antibody screen is negative, we don't do anything else.
Right, that's actually a good point, which is most people don't know that cross-matching, as we were taught originally where they mix the two together, doesn't happen anymore. It's
Unless
electronic
someone's
cross-matching
antibody
unless there's a
positive.
problem, yeah.
Right. So John, you mentioned the concern with prophylactic tranexamic acid, so I'm going to guess you don't use it prophylactically. Do you use it in all your treatment protocols for hemorrhage? And when do you give it? Early on?
We haven't formally incorporated it into any protocol. Of course, I think like a lot of us, we're just waiting for this huge body of evidence to be published from the woman trial, but it has dragged on a little bit. I think many of us think that there may be an advantage to its use prophylactically in some high-risk patients. I showed you one, the placental invasion disorder patient. However, I showed you kind of the one step too far, but it could very well be an ideal drug to use in that setting where you're anticipating a very high blood loss.
Half of my team give it prophylactically on the scheduled accreta per creta.
And
Dose?
for treatment? Do you use it for treatment?
No, prophylactic,
But
in
do
the, in the highest risk situation when you know there's going to be a massive blood loss.
1 gram load and 1 gram an hour? Is that
Just the load,
just a load?
see how it goes. Yeah.
Yep.
All right, question for Barbara and I guess Mark. The differences between the CMQCC and the ACOG bundles, is there much differences?
Few, because the person who was behind the formation of the CMQCC is also behind the formation of the National Partnership for Maternal Safety. I'm not familiar with all the details of the CMQCC toolkits, but I think there are a few differences. Mark?
Yes, there are a couple of minor differences, although I apologize, I can't quote them to you off the top of my head.
Question, one of the centers, OBs, asking for the Pitocin to be withheld until after delivery of the placenta rather than before. Evidence for one versus the other, that articles to throw in the face of the obstetrician was the request. Not verbatim, but
I know there is data that looked at giving it before or like right after delivery of the anterior shoulder versus waiting for delivery. And there was no difference in the incidence of retained placenta, which I think is what the obstetricians are always worried about. And the thinking was that there's, when the uterus contracts, that actually helps the placenta separate and expel. I don't know the reference, but I could find it out. If anyone's interested, email me because I know one of my colleagues has that reference off the top of his head. I could find it for you.
There might have been in my talk a reference that, I think one of the references, there was also a Cochrane review that about third stage of labor that didn't make it into my slide deck, so there's also that around from 2015, I want to say, that supports using it.
okay. Point of care testing, TEG, ROTEM, do any of the panelists use it? Any of the advantages to using it to guide hemorrhage?
I think this was an area of debate in the ASA guidelines. This was a panel that was a working group that was heavily represented by cardiac anesthesiologists, where they have strongly endorsed the use of it. And what it's shown in the cardiac literature, which I suspect it might show in the obstetric literature as well, is that its employment will be transfusion sparing, not just of red cells, but maybe more so of plasma and platelets, that generally people in the setting where they think they might be developing coagulopathy end up reassured with this test. We've just, I think we experimented with it years ago, mostly as a research tool. We've incorporated it in the last year, and we're just trying to determine now where to use it. But I think where a lot of people are interested in developing some reassurance on patients who have a strong indication for neuroaxial anesthesia, but there's something marginal about their clinical picture regarding coagulopathy.
A question, interesting question. So if magnesium and calcium channel blockers are associated with uterine atony, is there any role for calcium in the management of these cases?
Well, I would venture yes. I routinely, if things are, we're moving on and someone's bleeding a lot, I will use calcium, IV calcium chloride is the one we have available as a supplement, certainly to reverse magnesium if they're bleeding or if they've been on a calcium channel blocker, and occasionally if we've gone multiple drugs and things aren't working, I feel there's not much to lose. I'll just give the calcium, and it's a non-scientific series. I've occasionally had responses to the uterotonics after IV calcium that wasn't there before.
I guess we don't do that. I'm not aware of evidence. I understand the theoretical advantage of what you're describing, but I guess I would have to see some evidence. A little downside to it probably, right? In small doses. I'm just not aware that it's efficacious.
We're running out of time, so there's some really good questions. You're going to have to grab the panelists afterwards, but we'll just do one more. So Department of Defense has instituted a protocol for 30 units of Pitocin after delivery. What are your thoughts on optimal Pitocin dosing to try and prevent uterine atony? And obviously anyone on the panel is welcome to answer it, or what are you using?
That's an infusion? Is that what this means?
Yes,
Or both?
I'm gonna
It's
guess.
infusion, yeah.
30 units and 500 ml, that's kind of the standard concentration that the nurses use for labor Pitocin, and so that's kind of become the thing, oh, this is what you should give afterwards. In terms of the rate and the frequency, I'll defer to my colleagues here.
Well, I mean, there are a lot of data out there on dose responses. I can tell you what we do, which is kind of based on the literature, but then it's also massaged a little bit to make it easy to remember. I think most units do use that 30 units in 500, and if you do the math, if you started at 300 cc's an hour, that's like a nice easy number to remember. That gets you to close to the top of the 95% confidence interval for most like low-risk patients. Then there's some data that actually came out of Northwestern a few years ago, indicating that patients who were in labor and were already on oxytocin had increased requirements. And again, if you do the math and then kind of fudge a little bit, you can double that to, well, because you got to make it easy for people to remember too. You can double that to 600. That gets you to right about the middle of the confidence interval. If someone's still bleeding, 900 gets you just over the top of the 95% confidence interval. So, you know, if it's literature based, but it's also just easy for everyone, 300, 600, 900. That's what we use.
All right, so we're overrunning because we've got a short break, so I'll see you in about 10 minutes. And I want to thank the panelists for a really interesting session. Thank you.